Hello everyone, welcome back to today's class. We are going to move on with musculoskeletal. I'm recording, by the way, if somebody's asking. I was uploading yesterday videos and they are still uploading. I have a little bit of a bad internet, so yeah. Anyway, for today we have the following. So musculoskeletal system. Hopefully today we'll be finishing it up. I mean the musculoskeletal. Dermatology not yet, but musculoskeletal, I think we are able to finish it today. First of all, let me start with the tumors of the musculoskeletal. So we are going to speak about different types of tumors of the bone and different types of tumor of the cartilage. And I'm not sure if we are going to speak about the tumors of the muscles. It's not mentioned, but I will tell you about it. So primary bone tumors and secondary bone tumors. Secondary bone tumors are much more common. What does it mean, secondary bone tumor? It means metastasis. Guys, the metastasis to the bone is much more common than anywhere else. In case of metastasis, the tumors can be either osteolytic or osteoblastic or a mixed type of tumors. Can someone tell me which tumor can give an osteolytic metastasis to the bone? Osteolytic means that the portion of that bone will be lost. Yeah, well, you are correct, is that Paget disease can give the osteolytic lesion, but I'm asking about an osteolytic tumor, a cancer of another organ that can move to the bone and create an osteolytic lesion in them. I hope you are thinking about, for example, multiple myeloma, right? Remember, in multiple myeloma, we had this little osteolytic lesions. Also, except multiple myeloma, we had thyroid cancer, and we also had non-small cell carcinoma, right? If you don't know where I'm getting this from, you can go back to pathology. They mention there different tumors and where they originate from. So you can see exactly right here. See, they write bone and bone metastasis. It's much more common than primary bone tumor. And they tell you that the lytic ones comes from the thyroid, the kidney, and the non-small cell lung cancer. I told you the mnemonic, the kind none, right? The kind none. So yeah, that's all of them are lytic. The for thyroid, kind for kidney, and none for non-small cell lung cancer. Okay, let's go to the next thing. So that was metastasis. Let's now speak about primary tumors of the bone. So primary bone tumors include the following. First of all, we have metastatic. They write metastatic is the more common than primary. Benign bone tumor start with an O, and they are more common in boys. Okay, so as you can see, the bone ones, most of them, not all of them, starts with an O. Osteochondroma, osteoma, osteoid osteoma, and osteoblastoma. There is a few things that I want you to master. I mean, a few finding with each one of these that when you see it, you know that you are dealing with this cancer. This concepts and this portion of the book is not easy because it has a lot of memorization, okay? So osteochondroma is the most common benign bone tumor, most likely under 25 years old, and it can affect the metaphysis of the bone. Let's take a look at exactly where is the metaphysis of the bone. So if this is a bone, and I'm going to put numbers 1, 2, 3, 4, and 5. Where is the metaphysis of the bone? It's 2 and 4. Excellent. Where is the epiphysis of the bone? One and 5. Okay, that's good. What about the diaphysis of the bone? Where is the diaphysis of the bone? 3. That's correct. So, epiphysis, metaphysis, diaphysis, metaphysis, epiphysis. Okay, so which one of these can grow? I mean, we have a child and he's getting taller. Which portion is actually getting taller? The answer is the metaphysis. Okay, the metaphysis. Good. So they write, in case of the osteochondroma, it's pretty typical for them to have this beta pneumonic type of X-ray. So they say lateral bony projection of a growth plate. So yeah, continuous with the more with the marrow space. So what does that even mean? So it looks something like this. So if this is the bone, right? This is the metaphysis. Okay, so this weird projection is the tumor. So let's take a look at it. Osteochondroma. Okay, can you see how it goes out? Inside of it, if you biopsy it, what you will find inside? The answer is bone marrow, right? It's just an outpouch of the bone. That's how they want you to think about it. It's an outpouch of the bone. So they say, lateral bone projection, it's covered by a cartilage cap, rarely transforms to osteosarcoma. Osteochondroma is benign. Chondrosarcoma is malignant. So let's take a look at it. You can see how it's projecting to the side. And they even show here that osteochondroma, it is going out from the metaphysis. So the next one is going to be osteoma. And the osteoma, let's see, it's in a middle-aged patient. It can affect the surface of the facial bone. Facial bone are considered as a flat bone, and it's associated with Gardner syndrome. Anybody remember what was Gardner syndrome? We spoke about it in GIT. So yeah, no, that was Cartaginer. You are thinking about something else. Gardner syndrome, it was that patient who had familial adenomatous polyposis, and in the same time he had like brain tumors, okay? Sorry, not brain, but bone tumors, right? That was Gardner syndrome. In contrast with Torkett syndrome, in Torkett syndrome we had a patient who had also FAP, which is familial adenomatous polyposis, in addition to what? Brain tumor, right? Brain tumor. Okay, so Gardner syndrome is FAP together with the osteomas. The osteomas most likely to affect the face, okay? So Gardner syndrome. You can see that, just a momento, looking for a good picture. Okay, can you see how it's big here, and here you can see the tumor just right here. This is an osteoma. So yeah, most likely to be in a flat bone. Osteoid osteoma, the most important characteristic thing of this one is the bane. Anyhow, it's adult, less than 25 years old, males more than females. It affects the cortex of the long bone, and there is something interesting about this one. So the pain will be worse at night. It's severe bone pain, and it's relieved by NSAIDs. They can mention for you in the exam that it's relieved by NSAIDs. When you see that, start thinking osteoid osteoma. Before I continue, I would like you to know about one thing. You need to differentiate osteoid osteoma. Look, the category of the patient that have it. Less than 25 years old, and the pain is and there is no masses coming out yet. So it can weirdly look similar to which other physiological condition? Which physiological condition have similar things? It is, what do you think? Well, it is going to be like the bone lengthening, okay? So the bone lengthening. Okay, so the bone lengthening can lead to that. Well, I said like somebody less than 25 years old. So the age, the young age, you cannot think about osteoporosis. In osteoporosis, you only think about it if somebody of age, which age we spoke about regarding osteoporosis? Yes, 65 plus. 65 plus. Okay. The next thing they say, so yeah, the bone mass is going to be less than 2 centimeters, and they say it's radiolucent. Okay, so osteoid core. So let's take a look at that. It's a punch out lesion. That's how you need to think about it. So you can see how it's radiolucent, which means basically black, right? So that's an osteoid core. So the pain is going to be relieved by NSAIDs, worse at night. So osteoblastoma, it's more commonly to affect the vertebra. Similar histology to an osteoid osteoma, which is basically you can see the small red cells, small blue cells. And it's going to be larger than 2 centimeters. So you see osteoid osteoma less than 2 centimeter. Osteoblastoma more than 2 centimeter. And the pain will be unresponsive to NSAIDs. Osteoblastoma tend to be much more severe. Okay, so the next one is chondroma. But by the way, guys, this one is benign, but this one is also benign. Benign, 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 benign. Okay, all of these are benign. So the next one, so why osteoblastoma? I'm saying that it's more severe because it's painful, and you cannot use NSAIDs to decrease the pain. You have to use a more strong medication. Which medication is much more stronger for relieving the pain? Not an NSAID. I want something that is not an NSAID. Diclofenac sodium is amazing for the bone, I agree, but something that is not an NSAID, you need to step it up because the pain is not going away with an NSAID. And the answer is correct. It is morphine. It is morphine. Okay. The next thing they write, chondroma. Chondroma can affect the medulla of the small bone of the hand and the feet. Chondro, what does the word chondro mean? The word chondro means actually cartilage. Okay? Cartilage. So they say, chondroma, medulla of the small bones of the hand and the feet, benign tumor of the cartilage. Good. So giant cell tumor, it's between 20 to 40 years old, and it's going to affect the epiphysis of the bone. It's quite interesting because it's the only tumor that affects the epiphysis of the bone. So I just used, like, I know this is ridiculous, but I just used to imagine a giant man sitting here and holding the bone from its epiphysis. That way, it used to remind me that giant cell tumor only affect the epiphysis of the bone. Okay. Yeah, so for the osteoid osteoma, it will most commonly affect the diaphysis. So the next one is going to be giant cell tumor, epiphysis of the bone, often the knee joint. Locally aggressive benign tumor, which means it can destroy everything around it, but it will not metastasize to another organ. Neoplastic mononuclear cells that expresses rank L. They express rank L. So what is the origin of them? What do you think? Excellent. It's an osteoclast. So, and wait. So basically the idea is like this. Yeah, I felt it. Okay, so I just made a mistake. Their origin is osteoblast, but they are highly associated with the osteoclast. That's something I always get wrong, but it's okay. Yeah, so, but basically, they have the rank L on them. Wait a second, I just made a mistake. They have rank L, but they are considered to be osteoclastoma. We call it sometimes even. Osteoclastoma is the same thing. Yeah, so giant cell tumor, back in the time, it used to be named osteoclastoma. So it actually comes from the osteoclast, not the osteoblast. So yeah, you can see how it's affecting the knee joint, mostly the epiphysis of the bone, which is the distalmost portion of the bone. See, this is a joint. This is even a better picture. Can you see the bubbling? They call it a soap bubble. Soap bubble. Okay? So soap bubble lesion. Okay. Let me take this one. Okay, well, that will do it as well. Okay, soap bubble lesion in the epiphysis of the bone. Good. So they say soap bubble appearance on X-ray, as you can see here. So this one was what? The first one was the osteochondroma, osteoid osteoma, get relieved by NSAIDs. And this one is going to be the soap bubble lesion in giant cell tumor. Okay, so all of these are benign. Now let's speak about the malignant one. We have osteosarcoma, chondrosarcoma, Ewing sarcoma. Notice, all of the bone, what do we consider the bone? Are we considering the bone to be an epithelial tissue or some type of a mesenchymal tissue? No, the bone is not an epithelial tissue. It's a mesenchymal tissue. The glands, what do you think about the glands? Glands are epithelial tissue. So try to make a little like a table of them. So first one, epithelial tissue. Under it we have what? Skin, glands, and all of the covering of the internal organs, like the enterocytes, right? Also the endothelial cells. Mesenchymal tissue include blood, bone, cartilage. Yeah. So, okay, osteosarcoma accounts for 20% of primary bone tumors. The peak incidence of primary tumors in males, it's when they are less than 20 years old. So it's more common in the young fellows. It's less common in the elderly. Why? Because, and if it occurs in the elderly, it will be something like from like secondary to some predisposing factor that is really specialized in this patient. So it's not metastasis. Why? Because it says osteosarcoma. So the original tumor is an osteo, okay? So it must be some other disease of the bone leading to this bone problem. So it can be Paget disease of the bone, remember, except of the, like the osteosarcoma. There was one more complication of the Paget disease of the bone. Do you remember what was the second complication of the Paget disease of the bone? It's something cardiovascular. Yes, what was it exactly? Increased cardiac output heart failure. And why that happened? Because of formation of atriovenous malformation, which basically is going to bypass the blood from the arteries to the vein, which is going to increase the preload of the heart, and eventually the increase of the preload of the heart is going to going back to the heart, which is increasing the cardiac output. And when this keep happening, eventually the patient will have heart failure. Yes, exactly. Atriovenous malformation, it's an AV fistula, basically. Correct. So, the next thing they say, peak incidence of primary tumors in male less than 20, less common in elderly, usually secondary to a predisposing factor in the elderly, like Paget disease of the bone, bone infarction, radiation, familial retinoblastoma. Remember, retinoblastoma gene. The R stands for what? Retinoblastoma. The B for bone tumor. Which one? Osteosarcoma. And Leaf-Reymann syndrome. B53 deficiency. So, metaphysis of the long bone is the most likely to be affected. And what are we going to see? We are going to see a pleomorphic. Pleomorphic means what? It looks weird. That's what it means. Okay. So they say a pleomorphic osteoid producing cells, which is the malignant cells basically. And any malignant cells, what will happen to the size of its nucleus? The malignant cells. There is something that is going to happen to the side of the nucleus. It's going to increase significantly because they contain more DNA. And why these cancer cells have more DNA? The answer is because they want to proliferate more often. Notice here, it's pleomorphic, which means that it's not organized in one fashion. It's all over the place, basically. So yeah, it's unorganized. Okay. So pleomorphic and osteoid producing cells to present as a painful enlarging mass or a pathological fracture. These patients can have basically a radiological finding known as Codman triangle, which is an elevation of the periosteum in a shape of a triangle, or the sunburst appearance. So let's take a look at this. So this is the Codman triangle. I hope you can appreciate it. It looks like this, right? So it's a triangle. And if they ask you, what is it made out of? The answer is the periosteum. Okay? The answer is periosteum. Okay. So they say, sunburst appearance as well can occur. And as you can see, it just like the bone just has exploded. That's how I like to think about it. And the next thing is going to be like this sunburst appearance, and basically this is not specific for the osteosarcoma. What do I mean by that? It means that some other tumors can have it as well. I'm speaking about the osteosarcoma, the sunburst appearance. Rarely, except of the onion shaping in case of Ewing sarcoma, they can have the sunburst appearance. So be careful about that. So the tumors in case of osteosarcoma is quite aggressive, of course, because it's malignant, but it can be responsive to surgery and chemotherapy. So if it was a primary, it's much better. But if it was secondary, secondary to one of these diseases, it sucks. Poor prognosis. So chondrosarcoma, medulla of the pelvis can be affected, like the pelvic bone, and the proximal femur as well. So basically it's chondro, like it's the same idea of the chondroma, right? But instead of a benign tumor of the cartilage, we have a malignant tumor of the cartilage. This is low yield, this one is high yield actually. This one is low yield. So yeah, tumors with malignant chondrocytes. Ewing sarcoma, on the other hand, most commonly in a white patient, really young, more than 15. Notice actually most of the bone tumors are occurring in the young population. So this will affect the diaphysis of the bone. Contrast that with the osteosarcoma that affects the metaphysis of the bone. Okay, so the diaphysis of the bone, especially in the femur, pelvic flat bone as well. So what are the pelvic flat bone? They are speaking about the ischium, the ilium, and the iliac bone, right? So anaplastic is small blue cells of neuroectodermal origin. So you can see it just right here. Yes, when they tell you it's a neuroectodermal origin, it's basically asking you what are basically the markers for it. I mean, in immunohistochemistry, since it's from a neuroectodermal origin, it can be what? Neuroectodermal origin tumors. If I can stain them positive for what? Let me give you three options. Vimentin, synaptophysin, or keratin. So the correct answer is going to be synaptophysin. Keratin is for the epithelial cells. Vimentin is for the muscles. and the synaptophysin is from for the neuroectodermal origin cells. Where do I know this from? It's from pathology. If you remember, in the tumors we had like, there it is, yes, also yes, you can see here like yeah, see, you can see that some tumors can have this specific markers, and each tumor has its specific markers. So S100, I don't think so. S100, it should come from neuronal crust. So for example, if I'm speaking with you about some like tumors originating from the myelin, you would be like, okay, so schwannoma, for example, schwannoma, Schwann cells tumor. Schwann cells are from neuronal crust cells, and that is basically S100 positive, right? So let's take a look at the next one. One momento. So they say here, differentiated from condition with similar morphology like lymphoma and chronic osteomyelitis. Osteomyelitis will have fever. Lymphoma will have a massive weight loss. This one can also have a weight loss, but basically the X-ray will show something different. Let me write X-ray here, because if they don't mention it, we have to mention it. So by test, so they write you can differentiate it by also one more way, which is immunohistochemistry or genetics. So they have a translocation 1122, which create a fusion of protein known as basically Ewing sarcoma FLI1. And yeah, they will have this onion skinning of the periosteum. They love to show this picture. I don't know why there is no picture of this here, so I have to show it to you because it's actually common the exam. They can show you a Ewing sarcoma. So yeah, as you can see, each tumor has its thing that you need to memorize, you know? Like this one has the onion peel, the osteoid osteoma has the bane that is relieved by NSAIDs. So yeah, I hope you can see this is the periosteum and it's just going out, right? So yeah, that's the onioning of the bone. Can you see? It's just like a, it's like layering. It's like if you get an onion and you cut it, it has multiple layers, right? So that is it. Okay. So it's aggressive with early metastasis, but responsive to chemotherapy. Now there is some type, I'm not sure, I think he's a basketball player. His name is Patrick Ewing, and he has a jersey basically that has, I think, number 11 or something. I'm not sure about that. It's just something related to sport. I really don't know. So they write here where every tumor is located. So Ewing sarcoma, we saw it about the diaphysis. Osteoid osteoma, diaphysis. Osteosarcoma and chondroma, metaphysis. Giant cells, remember the giant man holding the bone? It's going to be the epiphysis. So each tumor has its specific location that does not touch the other locations. Okay guys, so I will see you in 10 minutes. Hello everyone, welcome back. So now we are going to speak about gout. Before saying anything about gout, I want you to tell me about a disease in which we have increased amount of uric acid, but in the same time we have self-mutilation. I mean the kid will be eating his fingers, he will be eating his lips, and he will have increased uric acid. Does anybody remember which disease I'm speaking about? Lesch-Nyhan syndrome. Lesch-Nyhan syndrome. Yes. Excellent. Okay. So, gout. Gout. So, first of all, let me tell you the story about gout. A patient comes to you, 35 years old, He wake up suddenly at night with the severe pain of his toe, and it does not exist. Do you have it in your book? If you do, please send me a picture of it. If it exists in any of your books, please someone send it. We will do it after gout. But if it does not exist, I oh no, this one we cannot bypass it. It's important. So please take a good picture of it, like with the whole thing, and we will do it. Okay. So until then, let's discuss gout, and we'll come back to this page because this is actually a high yield concept. I just don't know why it's missing in my version. So gout, the finding is as follows. So acute inflammatory monoarthritis, which means it affects only one joint. Okay. So this one joint is going to be severely painful. The most common joint to be affected is the metatarsal joint in the foot. Okay. So it's just behind the big toe. Acute inflammatory monoarthritis. Monoarthritis is one joint. Oligoarthritis is two joints. Polyarthritis is a three or more joint, caused by a precipitation of monosodium urate crystals in the joint. So, the risk factors is male sex, hypertension, obesity, diabetes, or dyslipidemias. All of these are characteristic of something known as metabolic syndrome. Metabolic syndrome, it's when the patient have this disorder in which they are suffering. Okay, guys, which one is the correct one? I think it's the second one. Okay, so basically, metabolic syndrome, it's the patient will be obese, hyperglycemic, dyslipidemic, and hypertensive. Also, alcohol use. All of these are a predisposing factor for gout. So, metabolic syndrome is predisposing to gout. Now we will understand why. So why we have the increase in the uric acid, which leads to the gout? It could be either from underexcretion or overproduction. The undersecretion, they say, largely idiopathic. We don't know exactly why. Could be due to renal failure, and it can be exacerbated by certain medication, such as thiazide. In case of the thiazide will have some symptoms which are known as the hypergluc. If you remember, the hypergluc, it's unknown exactly why they happen, but they do. So let's take a look at the hypergluc. So the hypergluc include hyperglycemia, lipidemia, and uremia. Hyperuricemia is another way of saying hyperuric acid or increased in the uric acid. Okay. The next thing is going to be diarrhea. Yes, overproduction of uric acid, Lesch-Nyhan syndrome can be a cause, which you just told me about. They had the self-mutilation. They will have BRBB excess in that disease. Also, some cases when we have why BRBB excess lead to this disease? Because BRBB, if you remember, in the biochem in the beginning, we spoke about BRBB, where it is. So I have to go to the purine salvage pathway. So yeah, this is the BRBB. So excess BRBB will allow us to get more IMB and GMB, which will eventually go back to create us uric acid. So the most important thing, there was one more disease except Lesch-Nyhan syndrome that has self-mutilation. Do you remember which other disease except Lesch-Nyhan syndrome have self-mutilation? The other disease was Fragile X. Fragile X also have self-mutilation. Okay. So more cell turnover, such as in tumor lysis syndrome. In the tumor lysis syndrome, the patient has cancer, like leukemia, let's say. You give him a chemotherapeutic agent. The chemotherapeutic agent is going to destroy the tumor. The tumor, after all, it's made out of cells. The cells will be releasing potassium, and they will be releasing DNA. The DNA can be converted into purines and pyrimidines, and the purines eventually can be converted into uric acid. Okay? So, the next thing, let's see. Yes, they say von Gerke disease also can lead to it. Von Gerke disease, we did not learn it yet. It's a type of a glycogen storage disease. So yeah, basically we will speak about that when we reach it. So crystals are needle-shaped and negatively birefringent and they're polarized light. And we will understand that in a second. So what is this needle-shaped crystals? Basically, if a patient is complaining from the gout, you'll be like, oh, okay, so you have this horrible like inflammation of your joint. Let me take a little bit of a fluid. So you will stick in a needle and you will draw some fluid and you will put it in histology. So when you put a polarized light, if somebody don't know what is polarized light, it's like this black light, if you know what I mean. So it looks like this. Just a moment. Or dark light, or yes, this one. Okay. So yeah, basically on the histology and on the microscopy of the sample, you will be able to see what? The needle-shaped crystals. The needle-shaped crystals, they say they are negatively birefringent, which is basically means that they will be yellow. So somebody will be like, okay, how can I know the axis? They either are going to give it to you, okay? In this case, it's like this actually. They are going to give it to you. They are going to tell you the axis is like this. If they don't, you don't have to worry about it. Why? Because if they don't, just look at the picture. Can you see yellow and blue? Yes, I can see the yellow. I can see the blue. That's the end of the story. This is gout. If you only can see the blue and you cannot see the yellow, this is pseudo-gout. So if you can see only blue, pseudo-gout. If you can see blue and yellow, this is gout. So they write yellow under polarized light, blue under perpendicular light. So if the axis was like this, you can see all of the yellow crystals are parallel, right? Parallel to the axis. While if you go perpendicular to it, it's going to become blue. So what did they say next? Serum uric acid level may be normal during an acute attack. So now we'll speak about the symptoms. Asymptomatic joint destruction. So in that case, the joint will be swollen, red, and painful. It's quite painful in the patient. And actually, that's why they come to you. Most of the time, no symptoms, but the symptoms occur suddenly. And when they occur, they will be coming running to you. So even in gout, there is two types of treatment. There is acute treatment and there is chronic treatment. The treatment are totally different from each other. You cannot give chronic treatment for acute. You cannot give acute treatment for chronic. Classical manifestation is a painful in the MTB joint of the big toe. Let me show you this metatarsal joint. So basically the pain is just right here, the MTB joint, metatarsophalangeal joint, right? You can see how it is becoming like enlarged and you need to tap it. Well, anytime you hear the word, you need to tap it. Tapping it means like putting a needle and taking fluid out, right? So, let's see. Okay, so when you take that fluid out, you are going to see this thing. So the right tophus formation can occur, which is this enlargement, and often on the external ear can be seen, especially with this little whitish crystals. And yeah, and olecranium bursa or the Achilles tendon. So they like to affect the soft tissue as well, like tendon, bursa, cartilage. They will be accumulating on them. This is true also in cases of dyslipidemias. When you have excess of something, it will start appearing on the skin. It doesn't matter. It is like uric acid or it is cholesterol. When you have too much of it, it will start appearing on your skin. Acute attacks tend to occur after a large meal with food rich in purines, like red meat and seafood. In addition to, actually on the exam, they will give you somebody who had seafood plus wine, okay? Because both of these contains a lot of cells, right? It doesn't matter actually, is it animal cells or plant cells? But basically they both contain cells, and when these cells are destroyed, they are going to release from the side of them what? What will the cell release from the inside of it? It's going to release DNA and potassium, okay? So they are going to release DNA and potassium. So when the DNA is released, it's going to be converted eventually into the DNA will be converted into purines, which is the building block, and eventually into uric acid. Okay, so yeah, DNA, purines, uric acid. DNA, purines, uric acid. So the next thing they write here for us is the following. Also it can be exacerbated by trauma, surgery, dehydration is a super important cause, or diuresis, especially after which diuretic can lead to acute attack of gout. Do you know which diuretic can lead to an acute attack of gout? So it's actually going to be thiazide, the hypergluc. Alcohol consumption, alcohol metabolites compete for the same excretion sites in the kidney as the uric acid. So when you drink the alcohol, it's going to fight with the uric acid, who's going to be secreted first. Because of that competition, the amount of the uric acid is going to increase in the blood, and it's going to decrease in the urine. So they write less uric acid secretion and subsequent buildup in the blood. So the treatment is totally different between acute and chronic, and that's you need to master. Why? Because if you give like a chronic patient an acute treatment, it's bad, and vice versa. So the acute treatment can be with NSAIDs like indomethacin. Why? Because it decreases the prostaglandin, so no prostaglandins, no pain. Glycocorticoids is the same deal. So why do we give the steroids? Because also decreases the pain. The third one is colchicine. Colchicine is a microtubule inhibitor. A logical human being will be like, how the hell this is even related? Okay, we have uric acid crystals inside of the joint. This is atypical for our body. So your body would like to defend itself from the uric acid crystals. So if this is a uric acid crystals, a macrophage will come and be like, uric acid crystals, let me eat it. So when he takes it in, the uric acid crystals is going to go inside of the cell, and it's going to enter something known as the phagosome. Okay, so this is inside of a phagosome now. The macrophage would like to combine the phagosome into something known as the lysosome. So it wanna create something called the phagolysosome. So what is phagolysosome? Is a combination between a phagosome, which contain the uric acid crystals, and the lysosome, which have hydrolytic enzyme. After formation, how can he combine them together? Utilizing something known as microtubules, okay? So after microtubules combine the phagosome to the lysosome, they will form something called the phagolysosome. So, and the uric acid crystal will be here. I have a question. The uric acid crystal, is it a living creature? I mean, can you destroy it with hydrolytic type of enzymes, or it's indestructible? What do you think? You just say yes or no. Can you destroy it? You cannot destroy it because uric acid is just like it's a hard tissue. It's basically like having bone, a piece of bone. It's kind of really difficult to destroy. So it cannot be destroyed. Because of that, the macrophages will start calling for help. And the way he calls for help is by secreting cytokines. So the cytokines, when they are secreted, they are going to lead to further inflammation, okay? And this inflammation is going to be So this inflammation is going to be super serious. Why? Because it is the thing leading to the pain. So you need to attenuate the pain by giving what? By giving steroids. That's one thing. When you give the steroids, you will not have cytokines. When you give the NSAIDs, one of the cytokines released are prostaglandins. So if you give the NSAIDs, no prostaglandins. Also, you can stop it from the beginning. What do I mean? So you can stop the combination of the prostaglandins, of the phagosome into the lysosome. How can you stop this? You can stop this by utilizing colchicine. So colchicine is a microtubule inhibitor. So when you utilize a microtubule inhibitor, you will not have a phagolysosome, which means you will not have macrophage releasing more cytokines. Okay, so that's how colchicine works. So chronically, you can utilize something known as xanthine oxidase inhibitor, like allopurinol or febuxostat. So both of these you can take a look at in here. So yeah, in the purine salvage pathway, as you can see, the xanthine oxidase can be inhibiting with this medication. So if you inhibit it, you will not have uric acid, which means you treated the patient. So the next thing is going to be like this. Pseudogout, also known as calcium pyrophosphate deposition disease. It only happens, it's either going to be idiopathic, but in the USMLE, they are going to give you a patient with hemochromatosis. So hemochromatosis can predispose for calcium pyrophosphate deposition disease, also known as pseudogout. So the symptoms will be like gout, but it's not gout. So previously called pseudogout, deposition of calcium pyrophosphate crystals within the joint spaces. It occurs in the patient older than 50, so elderly patient, and it can affect both males and females. Mostly it's idiopathic, which means we have no idea why it happens, but in the USMLE, it will be a patient with hemochromatosis. Can you please remind me, is hemochromatosis a problem in the intestine or a problem in the liver? It's in the intestine, absolutely. It's in the intestine. So, it's an overabsorption disease, which means after you do liver transplantation, you will not have a cure, okay? The next cause that can occur is hyperparathyroidism, because that can increase the amount of calcium, and joint trauma. So pain and the swelling of the with an acute inflammation, it's pseudogout. Or it can lead to chronic degeneration, which is basically like pseudo-osteoarthritis. It looks like an osteoarthritis, but it's not. Most commonly affects the joint of the knee. Don't confuse it with gout. Gout mostly affects which joint? The MTB, the metatarsopharyngeal joint, or the toe joint, right? So they write here, chondrocalcinosis can occur, in which we have cartilage calcification on an X-ray. I will teach you a trick of a pseudogout. If you understand it now, it doesn't matter which X-ray they will give you, you will always get it right. So when you take a look at a pseudogout, what I want you to do is something like this. Take the X-ray, put it in front of you, and enlarge it. So after you enlarge it, I want you to do this. So this is the X-ray. You can see that So let me just make this 3. Okay, you can see black, white, black, right? So there is black, white, black. So the calcification is inside of the joint. The calcification is not coming out from the joint. Even here, you can see here black, white, black, black, white, black. So when you see this, this is confirmatory of a pseudogout. So a pseudogout, it's a calcification directly in the cartilage, okay? So the next thing I'm going to speak of, so yeah, chondrocalcinosis directly into the cartilage. Crystals are going to be rhomboid and weakly positively birefringence under polarized light, which means they are going to be blue parallel to the light. Of course, they are not giving you the axis here, so that is completely useless. But can you see any yellow here? The answer is no. Because you cannot see any yellow, that's it. This is a pseudo gout, not gout. In the gout, you will have the yellow color. So, they write, crystals are rhomboid shaped and weakly positively birefringent. This is the rhomboid shape, by the way. So they say there is the following type of treatment. So yeah, the treatment could be with NSAIDs, colchicine, and the steroids as well. And for prophylaxis, you also can utilize colchicine. I want you to notice, we are not using an antiuric acid treatment. We are not using allopurinol, nofibixostate, which are xanthine oxidase inhibitor, because the problem here is unrelated to the uric acid. So there is multiple B's here. Blue, when parallel, positively birefringent, calcium pyrophosphate, pseudogout. Please don't forget about the hemochromatosis, because that's how they give it for you. So I got two pictures. I really don't know which one is what. So let me take a look. Just I don't want to do it and then move on and find it in the way. Just let me take a look. Guys, like some of you sent like two pictures. The one with the version 2021. Which one is it? 2021. Okay, so I think I'm just going to do this one. Okay, good. So let's see. We have osteoarthritis and rheumatoid arthritis. These two concepts you need to master. You need to be able to differentiate between the two. In osteoarthritis, it's an old people disease, mostly older than like 65 years old, okay? And they say as following. The thing is going to be as follow. It says, the first cause, it could be mechanical wear and tear, destruction of the articular cartilage. The picture did not load when I sent. Okay, good, no problem. So they say here it's mechanical wear and tear, destruction of the articular cartilage. So we consider it as a degenerative disease. Degenerative disease basically means that it is time thing. It's like aortic stenosis. The most common cause of aortic stenosis is age, you know? So the same with osteoarthritis. Inflammation with inadequate repair. Chondrocytes mediate degradation and inadequate repair. Please keep in mind, yes, there is some inflammation, but the main problem here is the degeneration. We cannot consider it as an inflammatory disease. We consider it as to be a degenerative disease. This is important. Why? Because osteoarthritis versus rheumatoid arthritis, which one of the two can have amyloidosis, and which one of the two, just which one can have the amyloidosis? Rheumatoid arthritis, absolutely correct. If you speak about osteoarthritis, it's impossible because it does not have chronic inflammation, right? So the predisposing factors are going to be as follow. It's going to be age, female, obesity, and joint trauma. So it's an old lady, right? So yeah, elderly, female, obesity, and joint trauma. So the pain is in the weight-bearing joint after use. Well, after use, that means at the end of the day. It's that lady who tells you, oh son, I cannot sleep from the pain of my knee or my back or my leg, right? Do not mistake that to plantar fasciitis. Plantar fasciitis, the pain was early in the morning. So they write, it improves with the rest. Asymmetric joint involvement and knee cartilage loss begins medially. So they will have the bow-legged as well, but no systemic symptoms. Why? Because it's a degenerative disease. It's not an actual inflammatory disease. So these patients are going to have formation of osteophytes. You need to know what is an osteophyte. As you can see here, there is this outgrowth of the bone, right? Here. This is an osteophyte. They like to show you an X-ray with osteophyte. So osteoarthritis. Okay, so in osteoarthritis, I hope you can see this. See this like thing jumping out? This is an osteophyte. Okay, except of the osteophyte, what did they write in first aid? Because except first aid, I'm going to tell you something else, actually. So they say you can see an osteophyte, a space, oh yeah, joint space narrowing. That's important. Subchondral sclerosis and cyst. This is super rare to have subchondral cyst on the X-ray. But for the sake of the USMLE, it's really common to ask about this. It's actually kind of difficult to find it. I mean, as a, yes, so they, good. So you can see the subchondral cyst. Okay, do not mistaking it with which tumor can have similar bubbling lesion. Which tumor can have a bubbling lesion, but that one will be in a young patient? Bone tumor with bubbles at the epiphysis. Excellent, somebody right? Giant, yes, giant cell tumor. Okay, good. So they write here, okay, synovial fluid will be non-inflammatory, obviously, because it's not an inflammatory disease, so the white blood cells are going to be less than 2000. So it's going to have development of two nodes, the hybridin nodes and the Bouchard nodes. The hybridin nodes are in the DIB, and the Bouchard nodes at the BIB. Actually, you have to know the names of each one. I remember, basically this one is more proximal to your body, right? The Bouchard node is more proximal to your body. So let me show you this. So you can see that we have, yes, the Bouchard and the hybridin nodes. If you forget which one is first, remember, bros before hose, so B's before H. So this is in the BIB, this is in the DIB. Okay, so in case of the osteoarthritis, we have involvement in both of them. In case of rheumatoid arthritis, it's going to be only the BIB, okay? Also in osteoarthritis, we have the carbon-metacarpal joint involvement, but no MCB, no knuckle involvement, basically. So the treatment is activity modification. You need to teach the patient that they need to make their muscles stronger. Why? Because if you make this muscle stronger, the pressure on that joint is going to decrease. Acetaminophen, NSAIDs, and intra-articular steroids all will decrease the pain, okay? So the next thing they say is about rheumatoid arthritis. This one is actually inflammatory, and it can lead to formation of the Banus. The Banus is a condition. Is this picture complete? I believe there should be something here. So autoimmune inflammation induces formation of the Banus. The Banus is just like a hyperproliferation of the tissue in rheumatoid arthritis. Banus, yes. Let's take a look at it. Just will be extra big. Just a moment. Okay, good enough. So you can see how big are the BIB are getting. Formation of Banus even here. Okay, here we go. So they say proliferative granulation tissue with an erode of articular cartilage and bone. Since it's an inflammatory condition, it can lead to amyloidosis. It's most commonly in the female. It's associated with an HLA-DR4. Remember, four-walled room or rheumatoid arthritis. Tobacco smoking can exacerbate the symptoms. The patient can have the rheumatic factor, but keep in mind, it's not always. So what is rheumatic factor? Yes, exactly. It's not sensitive because not in every single patient, okay? Also non-specific because it can be positive in other diseases, okay? So they say an IgM antibody. So remember IgM antibody and so IgG versus IgM. Which one is bigger in size? Absolutely, IgM is much bigger. So we have an IgM formed against an IgG FC region. And this IgG is going to be going against the bone, right? Rheumatic factor. It's positive in only 80% of the patient, which means not always it's going to be true. However, there is something called anti-citrullinated peptide. Oh, thank you so much. Anticyclic citrullinated peptide antibody. This one is much more specific. And they say, let's take a look actually at this, what just has been sent. Okay, so you can see this granulation tissue formation, the BANAS. The synovial fluid will be filled with inflammatory cells as well, right? And you can see the eroding of the bone, which means it's getting eaten up. However, here you can see the osteophyte formation, right? You can see the narrowing of the joint as well, right? Okay, so let's see what they write here. Pain, swelling, and morning stiffness lasting for more than an hour. So yeah, it's worse at morning. Improving with use, in contrast with osteoarthritis, which was getting worse with use. Asymmetric joint involvement will happen, and systemic symptoms like fever, fatigue, and weight loss will be. Extra articular manifestation are common, such as, for example, the rheumatic nodules, which is basically are going to be located under the skin, nodules located under the skin. They can be extra articular, which means not involving the joint. And they write, okay, let's see. Yes. Erosion, juxta-articular osteopnea, which means near the joint, they're going to be osteopnea, which is on the X-ray will look like decreased mineralization of the bone. Soft tissue swelling and subchondral cysts. Joint space narrowing will be seen, and deformities such as cervical subluxation of the neck. This is the lady who comes to you and tell you, oh, my neck is hurting me. And there will be an ulnar finger deviation, which looks like this, okay? This is highly specific of rheumatoid arthritis, which is the ulnar deviation. Okay, so yes, somebody once told me it looks like the goes like neck. Okay, can you see? This is ulnar deviation. Okay, good. The next thing. Good. So yeah, they can have this swan neck formation. Let's take a look at it. So yeah, you can see how it goes like up and down like a swan, right? Swan is this animal, the white one. Okay. Okay, so they also say here the boutonniere can be seen, which is basically this messed up fingers, as you can see like this. Why this is happening, guys? It's happening because the involvement in case of rheumatoid arthritis is only of the BIB. The DIB will not be involved. I repeat, the DIB will not be involved. So they say involvement of the MCB BIB, however, not the DIB. So the DIB is not involved. That's why we have the swan neck and the boutonniere type of presentation, because the DIB is still normal. The treatment is with NSAIDs, steroid, disease-modifying agents such as methotrexate and sulfasalazine, which is going to decrease the inflammation. Biological agents such as TNF-alpha inhibitor also can help decreasing the inflammation. They write here that except of the nodules, the subcutaneous nodules, lung involvement can happen, such as, for example, if you have a pneumoconiosis plus rheumatoid arthritis, we call that Kaplan syndrome. Okay. Also, some other condition can occur. For example, if you get lung disease plus you get blepharitis, pericarditis, anemia of chronic disease, this also can be possible. If you get neutropenia with splenomegaly and you get rheumatoid arthritis, so only neutropenia, splenomegaly, and rheumatoid arthritis, we call this the Felty syndrome. AA amyloidosis, which is a secondary type of amyloidosis. Sjogren syndrome, which is the dryness everywhere. Scleritis, and even carpal tunnel syndrome because of the inflammation. Okay, So that is it for these ones. The next thing we are going to speak about, yes, it's going to be systemic juvenile idiopathic arthritis. So systemic arthritis is going to be seen in a people less than 16. That's why we call it juvenile. So it usually presents with a daily spiking fever. So it goes like the patient has no fever, then it comes and then it goes back. Up, down, up, down. They can have a salmon pink malar rash, basically the arthritis. And can somebody tell me what other infectious disease can lead to some salmon colored rash? Good, salmonella. So, salmonella typhi, yes, salmonella typhi. So they say pink macular rash and yeah, arthritis, commonly more than 2 joints. It's associated with anterior uveitis and it frequently presents with leukocytosis, thrombocytosis, and anemia. Anemia of chronic disease, of course. And also, we have more ESR and more CRP. The treatment can be with NSAIDs, steroids, and methotrexate. Don't forget about the TNF inhibitor, which all decrease the inflammatory reaction. Okay, good. So let's see what they write next. Sjogren's syndrome. Sjogren's syndrome or the dry lady syndrome. So the dry lady we are speaking about today, her name is Rola, okay? Her name is Rola. She's a dry. So, Sjogren's syndrome. It's an autoimmune disorder characterized by destruction of all of the exocrine glands. Just know it like this. Destruction of the exocrine glands, and from here, that will help you to know most of the symptoms actually. Especially the lacrimal and the salivary gland. So, if you give this patient a dry cracker, can they make it wet and be able to swallow it, or they will be like for hours? Yeah, they cannot swallow it. It's just like it does not get wet. They have to drink it with something. They eat it with something. So yeah, and yeah, by lymphocytic infiltrate. I mean, the glands will have lymphocytic infiltrate. That's leading to their destruction, basically. Okay. So it predominantly affects the females. Why? Because most autoimmune disease affect the females. And the findings will be inflammatory joint pain, keratoconjunctivitis, which is inflammation of their eyes and conjunctiva. That will decrease. Why this happens? Because they don't have tears. Which animal don't have tears? Anybody know? There is one animal that cannot cry. The crocodile, absolutely. So yeah, these guys cannot cry as well, but this is not good because, you know, all the time we cry a little bit to keep our eye moist. So if this patient cannot moist their eye, they are going to get keratoconjunctivitis due to decreased tear production and subsequent corneal damage. Xerostomia, which is decreased saliva production. Zero means dry. Stomia means mouth, so their mouth will be dry. Mucosal atrophy and fissuring of the tongue can occur, as you can see here. So presence of anti-nuclear antibody can occur, and rheumatoid factor. So it can be positive in the absence of rheumatoid arthritis. So what's up with this patient? Anti-ribonucleoprotein antibody can be seen. And in addition to this, remember the Rola, the lady, the dry lady. Yes, so this patient can have anti-SSA, anti-SSP. What is anti-SSA? It's anti-Ro. What is anti-SSP? It's anti-La. So together, it's Rola, okay? So Rola is basically the antibody is against her because she's dry. Bilateral parotid enlargement. Why? Because basically we don't have secretion from the salivary gland and it's infiltrated with lymphocyte, which makes it big. So the next thing we have is anti-SSA and anti-SSP, also seen in lupus. So it's also will be seen in lupus. So what they say next? Okay, they say a common primary disorder or a secondary syndrome is associated with other autoimmune disorder like rheumatoid arthritis, lupus, and systemic sclerosis. Complications include dental caries, mucosa-associated lymphoid tissue, and lymphoma. It may present as parotid enlargement. More risk of giving birth to a baby with a neonatal lupus. Okay, so they can have a neonatal lupus. The neonatal lupus is no joke because the antibody for the lupus can pass, especially except of the lupus, there is one. Why this occurs? I will tell you. This is super serious. So this antibodies can also be anti-DNA antibodies, which can pass to the baby. And also the anti-Rho can go directly to the AV node of the heart, right? And they can have a heart block in a baby, an AV heart block in a baby, okay? So yeah, more risk of giving birth to a baby with a neonatal lupus. Focal lymphocytic sialadenitis on labial salivary gland biopsy can confirm the diagnosis. Okay, good. So septic arthritis. Septic arthritis is the next disease, and this patient is going to have the following. Staph aureus and streptococcus and Neisseria gonorrhea are common causes. So affected joint will be swallowing, as you can see. So they will be red and painful. Synovial fluid is purulent, which means white blood cells will be more than 50,000. Septic arthritis is the only disease, I repeat, septic arthritis is the only disease that will have a white blood cells in the joint tab that will be more than 50,000. If you see more than 50,000, it's septic arthritis. End of the story. Most of the time on the exam, they will give you a patient with Neisseria meningitis, disseminated gonococcal infection, an STI that presents with either a purulent arthritis in the knee, or it can be the triad, in which they will have like the pustule formation in their skin. They can have the multiple joint involvement all over the body, and they also can have tenosynovitis, which is inflammation of the tendon in their joints. So the next thing we speak about, let me just take a look. Okay. So the next thing to speak about is the seronegative spondylitis. So I hope you remember what is HLA-B27. Arthritis without rheumatic factor, so they do not have the IgA antibody. A strong association with the HLA-B27. It's only have one letter, so that makes it MHC class 1. So it's associated with the barium pneumonic, if you remember, which has what? It has psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. So they share some stuff together. For example, they can have a back pain with morning stiffness, and that can improve with exercise, especially ankylosing spondylitis, but it can be in any of them. They also can have peripheral arthritis and enthesitis. R for reactive arthritis. Reactive arthritis. Reactive arthritis, it's a condition in which they say cannot be, cannot see, cannot climb the tree, which means this patient is going to have urethritis, which is inflammation of the urethra, arthritis, cannot be, and uveitis, okay? So these patients with HLA-B27 also can have enthesitis, which is inflammation of the site of the insertion of the tendon, and dactylitis, which is inflammation of the fingers, making them look like big sausages, and uveitis, because of anterior uveitis, because of the association with the HLA-B27. Psoriatic arthritis associated with the skin psoriasis and nail lesion. I want you to master the nail lesion. Let's see, they don't show it here, but I will show it to you. So asymmetric and patchy involvement can occur on the hand. So yeah, a little bit of problem here, there, and in the same time they have the inflammation of the joint. So both skin symptoms and joint symptoms, right? Dactylitis can be seen with something known as pencil in the cap deformity in the DIB. Really bad picture. I have to show you both in a different aspect. So psoriatic arthritis. Okay, good. I hope you can see the bitting of the nails. Can you see the bitting of the nails? In addition to the bitting of the nails, you can see this oil colored nail, right? Like it looks like half of the nail is full with oil. So that's psoriatic arthritis. Sometimes some patient with hypothyroidism can have similar things. But notice, there is no bitting of the finger. There is no bitting. It's just like the oil shaped thing, but there is no bitting. So if you see the bitting, the end of the story, it's psoriatic arthritis. So they write, seen in fewer than 1/3 of the patient with the psoriasis. So it's quite rare. The next thing I want to show you, yes. As you can see, it's just entering the cap. There is almost no space, right? So this is the pencil in the cap appearance. Okay. Ankylosing spondylitis, asymmetrical involvement of the spine and the sacroiliac joint. So ankylosing or joint fusion, uveitis, and aortic regurgitation can happen. So we need to understand this a little bit. So the sacroiliac joint is basically the butt bone, is the most common bone to be involved. It's most commonly to occur in a young individual, and yes, when you take a look at the sacroiliac joint, which is this one, you cannot see it. As you can see, it's just like entering each other. Why? Because it's inflamed. So normally it should be plus or minus something like this. It should be more apparent, but when it's inflamed, they just like become one piece. So because they become like as you can see, just becoming like a one piece because of the inflammation. That's ankylosing spondylitis. This patient also can have uveitis and aortic regurg. You need to know about the aortic regurg. I'm not sure why it happens, but you need to know about it. Remember, it's a diastolic murmur. Bamboo spine can be seen because of vertebra fusion, basically, which looks like this. As you can see, this is the bamboo spine. Costovertebral and costosternal ankylosis may cause restrictive lung disease. Restrictive lung disease, when we speak about it, we will learn that the total lung capacity will decrease in that disease, but the FEV1 to FVC ratio is going to be normal or high. Restrictive lung disease can be due to internal lung pathology, preventing the inspiration and the air getting into the lung, or external lung pathology, preventing the lung from getting the air in, which is the situation here. So the musculoskeletal abnormalities is preventing our chest cavity from getting the air back to our lung. Monitor the degree of reduced chest wall expansion to assess disease severity. So it's according to how the expansion of the chest, the more severe the disease is going to be. It's more common in males, young males, okay? Inflammatory bowel disease is part of the barium mnemonic, so the I is for inflammatory bowel disease, which include Crohn's and ulcerative colitis, and they are also associated with the spondyloarthritis. Finally, reactive arthritis cannot see, cannot bend the knee, or cannot climb the tree. So that will be conjunctivitis, arthritis, and arthritis. So it's associated with bacteria most of the time. So Shigella, Campylobacter, E. coli, Salmonella. In addition to the ones that lead to sexually transmitted infections, such as chlamydia. Do not forget about Yersinia pestis, the cause of the plague, right? So let's take a little break here, and I will see you in 10 minutes to finish this thing up. Just to start the recording, and here we go. So the next topic is going to be about systemic lupus erythematosus. Okay, first of all, systemic, it affects all over the body. The idea here that we have formation of type 2 and type 3 hypersensitivity reaction. Type 2 hypersensitivity reaction, it's occurring because of formation of antibodies against the RBCs and the platelets. What I'm trying to say that the hematological symptoms in case of lupus are due to type 2 hypersensitivity reaction. While the organ destruction, like the kidney problem and the heart problem, or any other organ problem, it's going to be because of the immune complex formation, which is a type 3 hypersensitivity reaction, okay? So they say, systemic lupus erythematosus, systemic, remitting, and relapsing autoimmune disease, organ damage primarily due to a type 3 hypersensitivity reaction, and to a lesser degree, a type 2 hypersensitivity reaction. Remember, the type 2 mainly hematological stuff. So it's associated with a deficiency of early complement protein like the C1, a Q, C4, C2. Doesn't matter. Anything before C5 is considered to be early complement. That will lead to a less clearance of the immune complex. Classical presentation include rash. Remember the malar rash, the butterfly rash on the face. Joint pain will be seen as well in these patients because of the arthritis and fever. Mostly it's going to occur in ladies in reproductive age, and higher prevalence in the African American, the Caribbean, the Asian, and the Hispanics. In the US, similarly, they love to give you the Latino, the Hispanics. Okay, so it can lead to endocarditis, but the endocarditis goes something like this. The endocarditis goes as Liebman-Sachs endocarditis. It's kind of special. Why? Because it's not due to a bacteria. So it's a non-bacterial variceous thrombi, usually on the mitral or the aortic valve. It's quite interesting because normally the endocarditis is going to affect only one side. Yes, it's a sterile. Normally endocarditis affect one side, but in case of the Liebman-Sachs, it can affect either sides of the valve. So they write, it can present either surface of the valve, so it can be under or over surface, mostly under, but it can be also over, which is atypical for endocarditis. So they say, lupus nephritis, glomerular deposition of DNA and anti-DNA immune complexes. I told you, so the antibody is against DNA, right? So we have DNA, anti-DNA, and the complement together. They make the immune complex, which can lead to both nephritic and nephrotic syndrome, causing hematuria or proteinuria. Hematuria in nephritic, proteinuria in nephrotic. Most commonly and severe type is diffuse proliferative. Okay, common cause of death is what? Infectious cardiovascular disease. So yeah, it can accelerate the coronary artery disease, which can lead to the death of the patient. Kidney disease is the most common cause of death. Somebody once told me like the lupus, you know what lupus mean, I hope. Lupus means like a wolf, okay? Lupus is a wolf. He told me like the lupus is attacking the heart while looking at the kidney, okay? So why do we call it a wolf? Because if you look at the wolf, look around the eyes of the wolf, you can see this basically the malar rash, if it makes sense. The malar rash around the eye of the wolf. Okay, so what else? They say immune complexes are the thing that kills us because they are the ones leading to the Leading to the the organic symptoms. In an anti-SSA, which was seen in the, where did we see anti-SSA, the anti-Ro? Rolla, which was in which disease? Remember the dry lady. Sjogren disease, yes. Okay, so in an anti-SSA positive patient, they have an increased risk of the newborn developing neonatal lupus. In neonatal lupus, the anti-SSA is an IgG antibody which can pass into the fetus through the placenta, and it can go to the conduction system of the heart of the fetus, and it can lead to an AV block in the fetus. So congenital heart block, periorbital diffuse rash, and the transaminitis, which is inflammation of the, transaminitis, it's inflammatory condition of the liver, which increases the transaminases, and cytopenias at birth. So they write here, rash or pain. So the rash is going to be either malar, in which it's the one at the face, or discoid, which is I'd like to think about it as a de-skinning, just removing the skin literally in discoid rash. and arthritis, and also they can have serositis. What is serositis? It's inflammation of the layers that cover the organs. For example, it can lead to blepharitis, pericarditis, or peritonitis. Hematological disorders such as cytopenias, these are mediated by which type of hypersensitivity reaction? It's a type 2 hypersensitivity reaction. Again, I repeat, hematological disorder are a type 2 hypersensitivity reaction. The organ disorder are a type 3 hypersensitivity reaction. Oral or nasopharyngeal ulcers, which are going to be painless, renal disease, including both nephritic and nephrotic syndrome, photosensitivity, which is like fear of light, antinuclear antibody, and immunological disorder, such as the anti-double-stranded DNA and anti-Smith antibody and antiphospholipid antibody, in addition to the neurological disorders. Also, we can have seizures and psychosis in these patients, which is atypical in real life, but on the test, they like to tell you about it, and it is because of antibodies against the brain. Basically, even the brain is getting attacked. There is something known as mixed connective tissue disease, in which we have feature of the lupus, but they do have other connective tissue disease, such as systemic sclerosis or polymyositis, and is associated with an anti-U1 RNMB antibodies, which is also known as anti-topoisomerase antibody. Okay, so the antiphospholipid syndrome. Antiphospholipid syndrome has actually one clinical significance. So first of all, let's see what it is. Primary or secondary autoimmune disorder, most commonly in lupus, they can have this antiphospholipid syndrome. Diagnosed is based on a clinical criteria, including history of thrombosis. The main idea of antiphospholipid syndrome is a hypercoagulable state. So, arterial or venous thrombosis or a spontaneous abortion. Why? Because the baby also gets a thrombosis in him, which lead to abortion, along with laboratory finding with lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1 antibody. Basically, all of the problems here are multiple lupus antibodies, and the patient is in a hypercoagulable state that leads to thrombosis everywhere. They say now anticardiolipin antibody can cause a false positive VDRL RBR, which is the test used to diagnose what? What normally do we use the VDRL RBR for? Yeah, syphilis, absolutely. Syphilis. And venereal disease, absolutely. STDs. So, yeah, it can be false negative. So, when you get a positive test, you'll be like, you have syphilis. Oh my God, I'm sorry, you have antiphospholipid syndrome or lupus. No, give me syphilis. It's much easier. So, lupus anticoagulant can cause a prolonged PTT that do not correspond by an addition to normal platelet-free plasma. This is highly weird. Why? Because normally when we have a prolonged BTT, it means that you have a hypocoagulable state, correct? But in case of the antiphospholipid antibody, the presence of the lupus anticoagulant is going to give you a paradoxical increase in the BTT, which is false. So write a note. Regardless of the prolonged BTT, regardless of the falsely prolonged BTD due to the anticoagulant, lupus anticoagulant, the patient will still have hypercoagulable state. Okay? So the next thing they write here is about polymyalgia rheumatica. Remember, polymyalgia rheumatica is associated with one disease we spoke about in vasculitis. Does anybody remember it? Which disease in vasculitis is polymyalgia rheumatica associated with? It's associated with giant cell temporal arteritis. So symptoms include pain and stiffness in the proximal muscle, such as the shoulder or the hip. Often present with fever, malaise, weight loss, and does not cause muscle weakness. I want you to be careful. It's inflammatory condition, maybe, but it is for sure not a it's not going to lead to destruction of the muscle. So the muscle will not be destroyed, there will not be weakness. Yes, there is pain, yes, there's a stiffness, but there is no weakness, okay? So pain, stiffness, no weakness. More common in ladies more than 50 years old and is associated with giant cell temporal arteritis. The finding will include increased ESA and CRP because of the inflammation. But the normal CK, why? Because the muscle did not get destroyed. That's why we did not have weakness. So rapid response to low dose corticosteroid. Be careful. If the patient only have polyarteritis, polymyalgia rheumatica, you can give low dose steroid. But if he has giant cell temporal arteritis, you have to give high dose steroid. Fibromyalgia. Fibromyalgia, I truly don't believe in this disease. Most common in females 20 to 50 years old. Chronic widespread musculoskeletal pain. So when you ask the patient where it hurts, everywhere. So they call them the tender points. I will show you where they are located approximately. A lot of physicians think this is a psychological disorder more than it is being a real painful, like a real physical disorder. So you can see here the pain points, but they were more than this actually. And they write tender points, stiffness, paresthesia, borosity, fatigue, and cognitive disturbance. When you ask the patient, what do you mean by cognitive disturbance? They tell you, I feel like I am inside of water. I'm floating, okay? They tell you I'm floating. I don't know what's happening with me, doctor. Like sometimes I feel like I'm just floating inside of the water. This is the fibrofog, we call it, because of fibromyalgia. It's totally psychological condition, guys. The treatment is regular exercise, antidepressants like TCAs and SNRIs, and you give treatment for neurogenic pain, which is with gabapentin. The next diseases are polymyositis and dermatomyositis. Actually, this one has a real destruction of the muscle, which means the CK will be elevated. So we have non-specific antibodies for both of them. So ANA will be positive. ANA is positive in a lot of diseases. It's even positive in lupus. So CK will be high as well. The specific ones, however, is the anti-Jo one. So wait a second. The CK can be elevated in this, but also in other diseases. The ANA also can be elevated in this and other diseases. But these two diseases have a specific antibodies for them. It's not for one of them, it's for both of them. So this include anti-Jo, anti-SRB, and anti-MI2 antibodies. So the Jo is a histidyl-tRNA synthetase, and the SRB is a signal recognition particle, and the last one, MI, is the helicase. As you can see, all of these were playing a role in the process of gene expression. Please do not mistake the antibody against helicase with Bloom syndrome. That was due to a deficiency of helicase, not because of an antibody against it. Polymyositis. Polymyositis is a muscle-only disease. So a progressive symmetric proximal muscle weakness, like proximal shoulder and proximal thighs, characterized by an endomysial inflammation with a CD8 T cells, and the most often involves the shoulder. Okay, dermatomyositis. Dermatomyositis is going to involve both the skin and the myo, which is the what? The muscles. So clinically similar to polymyositis, however, it involves also the Gottron papules. What is Gottron papules? Gottron papules are something that can be seen on the hands. I hope you can see it here. So it's a type of edema and rash that occurs on the hand. And photo-distributed facial erythema as well, which is what? Like the heliotrope rash around the eyes, as you can see here, right? So, involving the eyelid. They can have this shell face and face rash. As you can see, it's over their face. It can go up to their chest as well. Darkening and thickening of the fingertips and size resulting in irregular appearing marks. And finally, they have more risk of malignancy, occult malignancy. Make a note, ovarian cancer. Actually, it can be any visceral cancer, but most commonly ovarian cancer. So perimesial inflammation and atrophy, and it's because of the CD8. CD8 is much more stronger than the CD4. CD4 is much more stronger than CD8. So I like to think since the CD4 is more a badass type of cell, it can affect both the CD4 and it can affect both the muscles, and it can affect, except of the muscle, the what? It can affect also the skin. While the polymyositis is because of CD8, so it's going to only affect the muscles. The next thing is a myositis ossificans, which is basically like the patient have nothing, suddenly gets a trauma. Myositis ossificans gets a really bad trauma, and this trauma is going to lead to calcification inside of the muscle. So they write heterotrophic ossification involving the skeletal muscle, especially the quadriceps muscles, and is associated with a blunt muscle trauma, presents as a painful soft tissue mass, and imaging show an eggshell calcification, which is something like this, eggshell calcification. So after a trauma, it's a type of metaplasia. It presents as a painful soft tissue mass. So we spoke about eggshell calcification. They write a metaplastic bone surrounding area. So it's a metaplasia. It's a muscle that converted into a bone, and have fibroblastic proliferation. This is creating the eggshell thing. It's benign, but sometimes you mistaken it to sarcoma. How to differentiate? Well, a sarcoma will be connected to the bone. This one is not connecting to the bone. As you can see, between it and the bone, there is a space. The next, so vasculitis was explained before in cardiac. Not going to go over it again. So the next thing is going to be the neuromuscular junction problem. So we have myasthenia gravis and we have the Lambert-Eaton. Both of them now we are speaking about the neuromuscular junction. At the neuromuscular junction, normally we have the action potential coming down, opening the calcium channels, which lead to the acetylcholine moving from here into the synaptic cleft. And after the acetylcholine will be released, it can bind into the postsynaptic cleft and lead to the action potential. The first disease, myasthenia gravis, most common neuromuscular junction disorder, it will have an autoantibody to the postsynaptic acetylcholine receptor. So when this antibody attaches here, it's going to destroy the receptor and endocytose it, which makes it dysfunctional. So that means action potential will not occur, which lead to a fatigable muscle weakness, ptosis, diplopia. Diplopia is double vision. Proximal muscle weakness, respiratory muscle involvement leading to dyspnea and restrictive lung disease. Bulbar muscle involvement as well. What are bulbar muscles? Are mostly muscles of the face. And also, in addition to the muscles of the face, we'll have basically all of the muscles that are supplied by cranial nerves, which include also the pharyngeal muscles, which can lead to dysphagia. Difficulty chewing, because also from the bulbar muscles. Bulbar muscles again are all of the muscles supplied by cranial nerves. And the spared reflexes. So it worsens with muscle use. So the more you use your muscle, the worse the symptoms are going to be. Why? Because you deplete your acetylcholine, right? So associated with thymoma and thymic hyperplasia. So keep in mind the thymoma is located in the anterior mediastinum. So if they mention an anterior mediastinal mass, think myasthenia gravis. They write acetylcholinesterase inhibitor administration. So this is something that is going to inhibit the acetylcholinesterase. Acetylcholinesterase, normally the function of it is to destroy the acetylcholine inside of the synapse. So if you inhibit it, the amount of acetylcholine is going to increase. So if the acetylcholine amount in the synapse is going to increase, why? Because normally there is this enzyme, let's say that this is the enzyme, And this guy, some of it will be destroyed by this guy, right? So now you are inhibiting it, which increases the bioavailability of the acetylcholine in the synapse, which relieves the symptoms. One example of it is pyridostigmine. Lambertitan, however, is uncommon. The antibody are due on the calcium channel. So now calcium channel working, no vesicles moving to the synaptic cleft, no acetylcholine release. So they write proximal muscle weakness, autonomic symptoms as well. The autonomic symptoms do not occur in myasthenia gravis. So the patient will have a dry mouth, constipation, and impotence, which is inability to attain erection. And hyporeflexia, don't forget that in myasthenia gravis, the reflexes are normal. And improves with muscle use. The more you use the muscles, the less the symptoms will be. It is associated with the small cell lung cancer, not thymoma. And if you give acetylcholinesterase, okay, inhibitor, so this is the enzyme. At the baseline, the enzyme was not working. Why? Because the acetylcholine is not released at all. It cannot be released at all. That's the pathology. So even if you give it, you will not help because there is no release of the acetylcholine from the synaptic cleft. That is the main problem. Raynaud phenomena, it's a decreased blood flow to the skin due to an arteriolar vasospasm in response to cold or stress. So it's genetically associated, okay? So the color will change from white to blue to red. So white means that the skin is getting ischemia because of the vasospasm. Blue, that's dangerous. That means it's hypoxic and yeah. And also it can become red. Why? Because you just came back into the house where it is warm and you have now the reperfusion. So most often in the fingers and the toes, which is the distal most portion of your body, which contains the smaller amount of the capillaries. So we call that Raynaud phenomenon, Raynaud disease when it is idiopathic, but we call it syndrome when you know the cause. So disease when you have no idea, and the syndrome when you do have the idea. So when secondary to a disease process such as mixed connective tissue disease, remember this disease, mixed connective tissue disease, meant that you had multiple autoimmune diseases at the same time, okay? And the next thing goes something like this. They say, Raynaud syndrome was secondary, okay, lupus as well, and the CREST syndrome. Do not forget that the CREST syndrome, the C stands for calcinosis or anti-centromere antibody, the R for Raynaud syndrome, the E for esophageal dysmotility, the S for sclerodactyly, which is the finger problem, and the T for telangiectasia, okay? So they say, limited form of systemic sclerosis. Yeah, because there's two types of systemic sclerosis. There is the limited form and there is the diffuse form. Also, we have digital ulceration, a critical ischemia seen in Raynaud syndrome. You can treat it with calcium channel blocker because they lead to vasodilatation and keeping the patient in the warm. Speaking of the devil, scleroderma, as we said, has two types. We have the diffuse type and there is the limited type. So systemic sclerosis have a triad of autoimmunity, non-inflammatory vesiculopathy, and collagen deposition with fibrosis. It's commonly sclerosis of the skin, manifesting with a buffy taut skin, as you can see here. Like, look, do you feel that this patient has, like, if she tries to smile, it's difficult for her. Their mimicry, like their face, don't have the wrinkles. Look, she looks like she's having Botox, no wrinkles, right? So yeah, but in the same time, she cannot smile normally, you know? So that is the basically what does taut skin mean. So yeah, without wrinkles. Fingertip will be bitting, as you can see, there is like this pits in their fingertips, and it can involve other organs such as the kidney, which can be the cause of death. So it can lead to scleroderma renal crisis, and you treat it with an ACE inhibitor because it's nephroprotective. In the lung, it can lead to interstitial fibrosis, which basically, if this is the alveole and this is the vessel, the fibrosis is going to be right here, which is going to decrease the O2 going to the vessel. And if you remember, the lung was the only organ that when you decrease the O2 going to it, what happens to the vessel? when you decrease the O2 going to the blood vessel in the lung only, the blood vessel is going to vasoconstrict, which is opposite to all other organs. The vasoconstriction of the vessel will predispose to pulmonary hypertension. GI symptoms include esophageal dysmotility and reflux and cardiovascular problems. Most of the time, it's females, as always, because it's autoimmune disease. Diffuse scleroderma, it's a widespread skin involvement, rapid progression, and early visceral involvement. The visceral involvement will most likely involve, again, the kidney and the lung. It's associated with an anti-SCL70 antibody, also known as anti-DNA topoisomerase 1 antibody, and anti-RNA polymerase 3. Please keep in mind the skin symptoms. Their skin will become so tight for them, okay? So the skin is going to become, diffuse scleroderma, is going to become super tight for them, which looks like something like this. Can you see? It's all of these problems here. So the last thing is I'm going to speak about now is limited scleroderma. Limited scleroderma, we have the Crest syndrome, which have the calcinosis cutis, anticentromere antibody, this is for the C. The R are rhinoid phenomena, esophageal dysmotility, sclerodactyly, which is basically the tight skin. So let's take a look at the sclerodactyly. So sclerodactyly, like, oh, okay, this guy. Damn it. Okay, let's see. Oh, this guy. Can you see? No wrinkles. The skin is so tight, right? It's really bad, actually, because after some times they start having the bitting, and after they have the bitting, they start having the necrosis and the infection of their fingers. Okay, so they can also have the telangiectasia. It has more benign clinical course. Okay, guys, so tomorrow we'll be doing dermatology, and on Saturday we'll be finishing up MSK and starting a new system. So see you guys tomorrow.